Everybody, welcome to another enthralling, exciting, and ingeniously developed podcast created by yours truly, Eric Rubenstein, Senior Director of Litigation, Fraud, Waste, and Abuse, and retired Senior Special Agent from the New York office of the OIG. Wade McFall, retired manager, ASAC, Assistant Special Agent in charge from the LA field office of the OIG, and a manager on our SAU team, and Matt Kachansky, who continues to change hats every day. Retired Special Agent in charge from the OIG, the retired Northeast UPIC Director, and his final stop, the Payment Integrity Director here at Advise Health. So we want to continue talking about some of these cases that are starting to come out, and we're seeing a lot of press releases starting to come out on cases that have been going on or that are new, whatever it may be, and talk about a case out of the District of New Jersey that we think is interesting, kickback case involving CGX testing, which is cancer testing. Similar to PGX and similar to the BRCA testing, it's just genetic testing done with a buccal swab, as they call it, B-U-C-C-A-L, buccal swab. I used to always think it was something other than buccal, but it's apparently pronounced buccal. And this case involved a Florida man. I always love when they say Florida man. There's a website, floridaman.com. It's a real thing, apparently. I don't understand why it's a Florida man versus New Jersey man or Maryland man or whatever it may be. But Florida man prosecuted out of Newark. And so people immediately go, oh, it's New Jersey. He's a Florida guy, but they found venue. The case originated out of New Jersey, and there were clearly going to be tests that were going to be rendered to the Medicare population in the New Jersey, in the District of New Jersey area. And so this is not really an interesting case in some regards. It's kind of the simple playbook that we've seen for years on end, and that we've seen for years and years on end. And again, we don't reinvent the wheel. The circus never changes. It's just who's the clown in the circus under the tent. And this is just another example. These cases are very reminiscent of each other. Telefraud is always going to be the base. Call centers, identity theft, social engineering. I think I've mentioned this before. There's a guy named Kevin Mitnick. You should look him up if you don't know who he is. Huge social engineering guy. And back in the day, before really computers were where they are, one pretty interesting thing with him was he was able to actually get plans and some source code for some Motorola phones back in the early days of the big Motorola phones through social engineering. People may know more recently, Frank Abagnale, the guy from the Catch Me If You Can movies, wrote a book, The Art of the Steal, and is one of the people that was responsible for some of the early security features on printed checks that you would handwrite. Fascinating guy. I've been to seminars with him, and if you've seen the movie or read his book, you know that he was a master at social engineering, and that's the way a lot of this comes through. It's when phone calls are made to Medicare beneficiaries and they have a little bit of information and they manipulate the person into giving away other information, and then you're kind of off to the races. And they said this case is not really notable in some regards. It was CGX testing, some social engineering, call centers, $1,200 per referral, ultimately for, a test that, ultimately resulted in potentially a lack of information. The key thing to remember on these is that when these tests are ordered, ultimately and signed by a doctor, there is from a licensure perspective, there is a responsibility on the provider to see through the care. So, for example, if someone had a test rendered and it resulted in some negative finding or aberrant finding, the doctor that ordered that test has a licensed responsibility in the state that they're in, for the most part, to provide that care and treatment for it. And so that's why you get a lot of doctors who are not willing to order certain tests if it's outside of their specialty, because they don't want to have to take ownership for it. An interesting one would be if you went to a gastroenterologist because your stomach was bothering you, and you had an x-ray or an ultrasound, and they have what's called an anecdotal finding. They find something on a kidney or your liver, something outside of what maybe a gastroenterologist might do, something that might be for a nephrologist or something like that. The doctor has to then deal with that, right? If you have something on the kidney, he's got to give you a referral. He's got to, deal with it. So the downside to these tests is, number one, it's typically a one and done test. The CGX, PGX, and a lot of this genetic testing, you can only get it once in your life. And if you're not getting it from the doctor that's actually treating you on a regular and routine basis as your primary care physician, those test results may never go anywhere. And I always talk about the case that I worked involving the Good Samaritans of America and a guy named Seth Reifus, all public record. He was paying kickbacks to nurse practitioners and healthcare providers who were taking responsibility for getting kickbacks for PGX testing, which is the way that your body metabolizes different types of medication. The problem is that if someone actually had an actionable result, none of the people that were getting the results were going to do anything. And most of the time, they weren't even getting the results. It's all tainted by kickbacks. But in this case, this guy was out getting $1,200 per test. And the tests were coming in from patients that were all over the country and things of that sort. And so the thing that's interesting about this was he was actually characterizing the money as expenses. So he was trying to actually legitimize that money. Again, and we talked about this last week, and I think we've talked about this a number of times, is that in these instances where the dollar amounts for these referrals are becoming higher and higher because the bounty is becoming higher. In this case, it was $1,200 a test. We've seen instances where it's been 50, 100, 100, a couple $100, $1,200 per test. You do 10, 12, 15 tests, you're talking about a lot of money. And when you start to get into these large dollar amounts, you can't drum up that kind of cash. It's just becoming more difficult because of reporting through banking and what they call FinCEN, Financial Crimes Investigation Center, which is part of Treasury, and what they call CTR, Currency Transaction Reports and Suspicious Activity Reports. This whole money laundering premise, if you try to transact something that's under 10,000, then you can potentially be looking at something called structuring. So whole separate issue, but the piece of it that is the engaging piece is providers are now having to try to find what they call, what we would probably characterize as novel approaches. We've looked at cases where they've done what they call MSOs, management service organizations, that come in, they're entirely shams, and they set up what are called MSAs, management services agreements. We've seen a whole bunch of cases involving rural hospitals doing that. There were a number of cases out of Texas where that was going on, Louisiana, I think Mississippi, where you saw these rural hospitals where there's a lot of pass-through in labs, and it's really just kickback schemes that are masked as legitimate income and things of that sort. Now, a lot of that, again, as we talk about, are going to be outside the purview of your special investigations units and the ability of an SIU to be able to get to that level of granularity. But again, Wade, I don't want to beat the horse dead, but we're going to reshoe it, and we're going to let that horse take a ride, because it really is an issue involving data analytics. And it really is going to come down to, when it is that we see these areas that are large dollar volume areas of known fraud, CGX, PGX, every time you open up a press release and you look at it, you kind of shake your head. You kind of do a face palm, right? Hand to the forehead, because it's like, again, but data tells you these things. And while you can't get some information from that SIU perspective, some of these pieces of the puzzle, while I'm not going to say it's easy, but some of these pieces of the puzzle, when you know some of these known fraud schemes and facts and codes, certainly can give you the ability to start working cases, that you may not already be looking at.
Right. There's definitely some limitations in the data, but as you're saying, the data is going to show you flags. We always talk about flags. In a case like this, where the entities, maybe the lab is in a different state, the physician is in a different state from the member or the beneficiary, all that stuff shows up on the data in the geo spacing, the geo tagging, even in the relationship from where the member is to, like, the referring physician might be in another state. So that stuff can show up on data pretty easily. Where we run into limitations for SIUs is your data sets, as far as claims data, are going to probably be limited to your state. If it's a Medicaid contract, you're going to be limited to your state. So you won't have data that's reaching into other states' databases, basically, of claims. But you can also do that once you get those flags from the data that you do have, and you can see that the claims are stretching from different states and different regions. There's a lot of research you can still do, just basic internet research, as far as, if you get a referring physician who's in another state, you won't maybe be able to get the claims data that for that physician, but you can at least find out where they are, find out where the lab is. You can do some pretty basic internet research that will give you a lot of information. As far as getting to those actual claims, this is another case where we run into the value of having either a law enforcement liaison or somebody who has connections outside of the SIU, because in a case like this, which is not typically the focus of an SIU, being able to reach out to somebody who has that wider jurisdiction, the wider data availability, it's worth pitching a case, or at least discussing it with somebody who has that further reach, whether it be an OIG agent, a Mufuku agent. Again, it's still going to be limited to the state, but OIG, FBI, different federal law enforcement, they may be interested in this, and they have a wider reach where they can get that data that the SIU is limited to. They can have access to that.
Yeah, and the one thing that will always continue to come up when we're talking about these ancillary services, right? So ancillary services are, obviously the things that come out of your primary care and orders that come out, right? Your MRIs, your lab work, DME and all of that. And the problem that we continue to have, and Matt, we talk about this incessantly, is the general time period that plans allow providers to submit claims. Yeah. And the fact that because of this back and forth involving things like prompt pay laws, and unless the claim is flagged for an FWA issue, and particularly in the CMS space, we're talking about a 14-day turnaround on claims, and the Clean Claims Acts that are out there, and then the state clean claims laws. The problem becomes that when the lab submits that claim, if it is a clean claim, meaning free of errors and or omissions, the provider, there's a fiduciary responsibility by the plan to pay it. There's they have a financial interest in getting it paid so that they can make sure that there's continuity of care and things of that sort. And the problem becomes that when the ordering provider either A, doesn't have an E&M, never saw the patient, didn't do anything, or B, there's some nonsense documentation because it's a telefraud case, and they never submit a claim anyway for that E&M, and there's no established relationship and all of that. These companies that are in the ancillary services world are looking to churn those claims out as quickly as possible, because they know it's just a matter of time until the sniff test results in something negative. And so from that payment integrity perspective, the question really kind of begs is payment integrity aligned with some way to do this algorithm to stop this from happening? And more importantly, I think we're all kind of getting a little tired of talking about these repeat things that are going on, and the fact that sometimes it's just nature. We're a pay and chase world, right? And so it's not a stop and verify world. But it sort of begs the other logical question of, should plans be really going from a payment integrity perspective and really making sure that are these high fraud known areas the top of the food chain? Because when you're vetting your cases, are you spending your time vetting these cases? Are you spending your time vetting other things? It's a little bit of this recalibration of priorities. And I think that part of the problem that exists in our industry is that everybody is so maxed out that we don't have the ability to recalibrate our priorities for the latest and greatest that's out there, because the fraud, waste, abuse people are always kind of a half a step ahead of us.
Yeah. And what we see, they are maxed out, and it might be because they are paying and chasing everything that comes their way. They've got the analytic tools that are generating lead after lead after lead after lead, and they're opening all of them. I'm going to open this one, this one, this one, this one, instead of using a little logic, using common sense, using your knowledge of the industry to say, this stuff, same circus, different clowns. Why don't we shut down the circus? Why don't we know that these genetic tests are an issue. We know that when it's combined with no prior history or with a diagnosis for this patient who's never had cancer in their history, we know they're bad, but we're still going to pay them because we have to, rather than Why don't we just find a different way and be proactive and put them on a prepay or suspend the payments, or just based on the pattern that we've seen throughout the history of program integrity? That would put a stop to a lot of the stuff. When I was with the UPIC, when we were with the OIG, how many papers did we submit saying, when you've got a claim for a ancillary test being ordered by a doctor that has no history with the patient, stop it? And the answer was always, well, as you said, the doctor has 6 months or a year to submit that claim. We can't stop it based on that. My thought is, why not? There's a 99% chance that it's fraud or abuse, where you might anger one doctor who, I was late getting my E&M bill in, but 99% of the time you're going to see that it is part of the scheme. When you see that a lab has a spike in their billings and they're all coming from referrals from 2 or 3 doctors that are out of state and have no history with these patients, stop those claims, don't pay them. They just have to go to this alternative and not worry about the financial obligation to pay these claims because they're submitted correctly. They're not submitted correctly. They're submitted with fraudulent intent. So treat them like that. That's when you get program integrity in line. The past 4 months we've been reading press releases, right? Those same press releases, change the dates, change the names. They've been going on for 20 years.
Yeah.
It's time to stop. 20, 30 years for me. My first case was a telemarketing case, involving wheelchairs.
Well, let me ask you this, Matt, because, the question that I think kind of comes to mind and that people will ask and that brings up, and by the way, I love when you're on social media and people love to get on and say, the number one question I get asked the most, I would like to know how many people have actually asked you that question, or are you just making that up? Because I don't really think that people get asked as many questions as they purport to be on social media, but that's just me. But I think the one thing that I know that comes out of a lot of discussions with our payors and in the industry when we talk about this, and particularly with things like data analytics, is when Wade McFall gets when Medicare or a payer gets a claim for a test for Wade McFall as a member of that plan, and the ordering doctor is Dr. Matt Kachansky, and Dr. Matt Kachansky has never, ever seen Wade McFall ever in the billing history, ever. And it looks pretty close to the fact that Wade McFall has been treated by other doctors and a, internal medicine doctor or whatever. And Wade McFall lives in New Jersey and Matt Kachansky lives in Florida. That should be a red flag. That should be something that someone says there's a problem with. And more importantly, if Wade McFall is getting a test, a CGX test for cancer, and Matt Kachansky is an ophthalmologist or an orthopedist or a nurse practitioner in dermatology or something that's an entire non sequitur, right? Because when you look at billing histories, you will see the referring or ordering provider's name, NPI, and then it's just a matter of going and looking to see what's their specialty. We're seeing a lot of these cases have nurse practitioners and physician assistants. Why is that? I don't know the real answer. We can all speculate. Some of it is probably financially based. NPs and PAs looking to make additional money. Very expensive to go to NP or PA school. You're not making the kind of money that MDs or DOs make or things like that. And so is it an opportunity, particularly in states where NPs and PAs do not have to work with collaborating physicians and things of that sort? But it sort of does beg the question of how is it that these claims continue to go through? And I think that as analytics become better, and I hate using it, AI, machine learning, whatever those really mean. It is what it is. But I think that at the end of the day, how is it that Wade McFall is getting a PGX test, a CGX test or something, and maybe Wade McFall has been on a statin for cholesterol for 20 years. Doing a PGX test to see if Wade McFall's body is going to metabolize that statin is absurd. You've been on it for 20 years. Your doctor's already determined what's the best course of action, and you haven't died from using it, and you haven't suffered any of the side effects from using it because you've been on it for 20 years. It's a little bit of a similar thing with how is it that Wade McFall, who may have an above the knee amputation of his left leg, gets a left knee brace when there's a clear history that he's had a prior above the knee amputation, which you don't, by the way, and thank God for that. No. But the point is, like, some of these are such obvious things that kind of beg the question as to why we're doing this. And I think part of this is because, right, Matt, is there's a constant evolution of analytics, and there's a constant evolution of the payment integrity working with analytics and payment integrity working with the SIU and the clinical and all of that. And the problem is that unfortunately, people don't have the ability to be in the same room all the time to do that. And so therefore they don't have that. And I think, one of the things that we would recommend is that these payers create working groups. It doesn't mean you have to meet every day or every week, but you have point persons so that when you have somebody on the analytics side saying, hey, we're seeing a spike in CGX testing to our plan. Oh, by the way, I did a little bit of Googling and I found that CGX is a known fraud scheme. Hey, payment integrity, what's the policy on CGX and PGX? Hey, SIU, should we look to work with payment integrity to come up with an algorithm to flag these? Should there be a policy? Should there be, right? I mean, these are not necessarily difficult conversations, but it's just making sure that everybody knows. Do the policy people know what the latest and greatest fraud schemes are? I don't know the answer. Do the analytics people know what the latest and greatest fraud schemes are? I don't know. The SIU people tend to know the latest and greatest fraud schemes only reactionarily, unless they are an investigator who's taking a proactive approach to things. So I think, going back to this case as we, kind of wrap ourselves up in this, is that it's less about the fact that this guy created false expenses to justify and then take tax deductions on his fraud, or characterize it as some other way within his books and records to be able to have the ability to pull that cash out for things. But it's really more about the endemic schemes that we're seeing that are kind of repeating themselves. And, again, they're not even building a better mousetrap. There's no Rube Goldbergs going on here. It's the same mousetrap. And I think that when we look at this across the payers and we start to hear about now CMS is creating the Fusion Center, right? And I don't know, is the Fusion Center going to do anything? Or is the Fusion Center just a renaming of things that already exist? We've talked about things like the Healthcare Fraud Prevention Partnership. We've talked about regional sharing things. We've talked about the OIG having the Division of Data Analytics, the DDA. We've talked about the strike forces using various tools. And so the question becomes, is adding another tool to your tool belt really making your tool belt better, or is it just making your tool belt heavier? I think it remains to be seen. But Matt, I want to give you the last kind of, on this, because we encounter this, and we encounter this particularly with a lot of our payer clients, where they want to know how can they get better ROI. And the one thing that we always talk to them about is prepay, which, again, going back to what they're now calling it, which is stop and verify. And we're seeing, because we're running a prepay team for a particular payer, and we're seeing unbelievable return on investment in that, right? Huge return on investment, because we're stopping these schemes, because we're seeing upticks in these outliers.
Right. And it is an outlier, you're outlaying a lot of resources to set up a prepay program. There is upfront expense, there is investment, but it can be targeted. It can be focused. If you have known fraud schemes and you've got people that are providers that are, just way over the norm, and just, you put those on prepay to stop them immediately, and then look at the entire program at that point, the testing, are there other ones that are not billing as much? Can you take other remedies against them? Maybe send them warning letters saying, if you don't stop, we're going to put you on prepay, or take other actions. And so that's less expensive. It might have the same type of savings effect that, your ROI, your return is going to go up through savings, both from the ones you're putting on prepay and the ones that hopefully you're changing their behavior by saying, we're watching it. And so there's different ways to do it that can save on your investment and still keep the same or even increase your return. And we've been playing with those with a lot of our clients, and we've been very successful in the plans implementing of those things. So there's solutions to it. Again, it's cutting, it's closing down the circus rather than, whack-a-mole in the clowns.
Right. And I think, I think the issue that plans sometimes have is whether it's trepidation because of provider abrasion, whether it's a lack of ability to stand up the prepay. But, we've now stood up prepay for a couple of plans. We have one that is inordinately successful, 5 or 6 to 1. And I'm not touting 5 or 6 to 1 in a negative way. You've got providers who are just billing things inappropriately. And we're not even saying necessarily that this is a fraud, waste, abuse, compliance. We're not bucketing it into one. We're not saying it's an F, a W, an A C for compliance. We're just saying, like, look, providers have identified themselves through their data and through prior interaction, whether it be some version of a TPE, which we've talked about before, targeted probe education. We recommend that as a very big piece to the puzzle, and letting TPE lead a provider to prepay, or if they're just an outlier from post-pay audits or something like that, to put them on that. But when you see a 5 to 6 ROI, and that's 5 to 6 ROI, including the costs of the program, we're not talking about raw numbers. We're talking about, like, if you're a finance person, the bottom line, 5 or 6 to 1 ROI. That's after expenses of standing it up. There are some fairly reasonably cost platforms, if people don't have them, that are used, and the audits can be done in a pretty timely manner that gets turnover done quickly. We're saying claims that should be paid will be paid, and claims that shouldn't be paid because of an issue with the documentation shouldn't. But when you look at a 5 to 6 ROI and you're looking at plans that have nothing in place, that plan's entire ROI on savings is coming from a bunch of kind of patchwork things, whether it be reactive cases from the SIU, whether it be proactive cases from doing data. And then in the proactive case on data, you're still having to vet the viability of that data and all of those things. And so there's a bunch of things that are out there. And I think it's surprising to me sometimes when I see how many of the payer community don't have any sort of prepay or even a TPE program, which obviously a TPE program winds up costing a lot less because you're not having to stand up necessarily an analytics platform to do the audits, stop the money. A TPE program can certainly be used in some manner that kind of melds your prepay, your postpay, and a bunch of things like that. So, I think there's a lot of things that are out there, but, are these cases going to go away? No, because when we're seeing millions of dollars going out the door, these PGX and CGX cases are $10,000, $12,000 reimbursements in some cases, for a $1,200 per referral amount. It's got to be a very expensive test to make it worth the while of people. I think with some of these, the days of $25 and $50 kickbacks are going to be relegated to some of the more benign things like the DME, where it's a $200 or $300 brace or something like that. But these cases are going to continue. The crooks will always find a way to build a better mousetrap for themselves, and we just need to stay ahead of the curve. But I think every day you open up and you read the funny paper press releases about these things, you just kind of at some point got to say, oh, it's just another day in the healthcare fraud, waste, abuse space. And so, I think there's things that we've got to be able to do on the payer side to kind of put an end to it and make the bad guys work harder, because right now they're not working very hard for all of this. And so we just need to be a little bit smarter on how we're going to do things.
And did you notice that the charging document was an information? So he's obviously cooperating against the co-conspirators that were unnamed in the press release.
So either cooperating and they're ready to charge the other people right at this point, or they got him and he just agreed to plead guilty, and they approached him and he's agreed to plead. I didn't see anything that even said that he was arrested previously on a complaint. So they may have approached him, had some evidence from another cooperator, and got him to cooperate as a result of that. There's probably video of something going on involving it, because that's usually the thing that makes people change their minds. Nothing better than having a covert video from a cooperator with the cash payments going on. Maybe at some point I'll show some video from some of the trials I had with cash payments going because it's public record, so I can show it. But sometimes that's the best evidence to get somebody to say maybe not.
You had some too, Wade, at the undercover clinic you guys ran.
Yeah. So that evidence is great evidence, and right, I suspect, Matt and Wade, that's probably the case. So as always, we're going to continue to we'll continue to beat the horse. We're putting new shoes on the horse because apparently just when we think we've gone and taken him out to pasture, we gotta saddle up and take him for a ride. Wade prefers to ride English style because he has knobby knees and he wears a long skirt, so he prefers to do that. But
I don't look good in a cowboy hat, so
I ride side saddle. So
yeah. Isn't that English? Isn't side saddle English? I don't know. It's not. I don't know.
How the proper female rides a horse.
Oh yeah. Again, we don't really ride horses in the Bronx where I grew up. So it's I think I've been near a horse once, maybe twice, maybe like a dude ranch as a kid that they would send us to go see what it's like to live in the country, and then I immediately got back on and went back to where the real animals are. NYC, baby. All right, good stuff as always. Matt, Wade, always good to get your input on things. Always appreciate people giving their input. We've got a bunch of great podcasts lined up, including at the end of the month, myself and one of our directors, Dan Olson, retired from Deloitte, data analytics guy forever, was part of a big leadership team at Illinois Medicaid for a number of years. He and I are going to be doing a LinkedIn Live at the end of the month. We're going to be talking about some things involving data analytics and creating algorithms and all that stuff. It's going to be a pretty interesting thing, I think. We know that this is the thing. Everybody wants to talk about data, so we're going to really do it. We're going to do it on a LinkedIn Live at the end of the month. So please keep your eyes open for that. It's going to be during the day. To go back and check. LinkedIn will show, and we'll be putting out the advertisements again. So, and as always, you can get our newsletter every Friday in your inbox. Get the podcasts on YouTube and on Spotify. So thanks everybody for tuning in. We appreciate everybody spending their day with us, and we'll see you on the next OIG Roundtable. Take care, everybody.
Thanks, everybody.
Thank you. Thanks.